Dr. Jonas is a phenomenal speaker, a phenomenal writer, a phenomenal thinker in terms of health and wellness. And this book is a tremendous book. It's contained in all your tote bags. I cannot recommend this book highly enough. And I would first thing, yeah, she did. She read it out loud, totally to me, and it blew my hair back, every page. So I would strongly recommend it as soon as you get back. Give it a good read this weekend, get it going, because it is phenomenal. So without further ado, Dr. Wayne Jonas. Thank you, sir.
Thank you. That was a phenomenal introduction. Thank you. Appreciate that. It's great to be here. This is fantastic. And I like the intimacy of this group, the discussions in the small groups, the time that we've had to really talk about this. Is that okay? Everybody hear me all right? And so I really appreciate the opportunity to make it even harder than the discussions we've had this morning. As I was thinking about how to put the challenges around appropriate management of chronic pain into context, I thought, well, let me frame this in an even larger and even more difficult problem. It's not the largest one that's out there, but it is sort of the next level. And I thought, gee, that would be too discouraging this morning as we were looking at all these challenges. But I'll have to say I was very pleasantly surprised and encouraged to see the progress that has been made on the National Pain Strategy. It actually is very much like most government things. There's some that go forward very far, and there's others that don't move very far, and there's something in between and that type of thing. And that is in some ways very encouraging because it means there is some progress in these areas. And so what I hope to do is enlarge in the context of the chronic pain issue and illustrate to you that by solving that issue or by focusing on that issue, we'll actually be impacting a much larger issue, which is our management of chronic disease in general, which is broken in this country. And the data shows, the science and the research show that it's broken in this country, and yet we still haven't quite mustered the motivation to really do the redesign fix that would be required and that many other countries have done and have shown that there are ways that you can improve chronic illness, you can prevent illness, you can reduce costs, improve outcomes if you'll pay attention to how you go about delivering it. And then at the end, I'm going to give you some suggestions that you can do today, you can do right now in these areas. So that we don't have to wait for the policy changes to take their fruition, although we'll continue to work on those, but we can connect them with on-the-ground action that every person, every family member, whether they're a patient or not, and every provider can actually do today to change the way we deliver care. I'm going to read this one little sentence from the National Pain Strategy, which to me is the most crucial sentence, at least it stood out for me. The National Pain Strategy recommends population-based biopsychosocial, say that 5 times really rapidly, approach to pain care that is grounded in scientific evidence, integrated, multimodal, and interdisciplinary, while tailored to an individual patient's needs. If that isn't a government phrase, a committee construction, I don't know what is. Let me rephrase it. We need a strategy that is holistic, evidence-based, integrated with teams that actually work together, person-centered. That's all in my acronyms. That's not just for pain. That has been the mantra for healthcare policy recommendations coming out of IOM in all areas for many, many decades. Crossing the Quality Chasm, 2001. Many of you may have remembered that, also an IOM report, called for the exact same thing. How do we do this? How do we make this happen? We've had a lot of discussion around cultural change. And I suggest that if we start at the policy level, The very first thing is that we're actually asking the wrong question. How many here are for universal health insurance? Dare you put your hand up? Universal health coverage. All civilized countries except this one have one, and actually most uncivilized countries actually have one. Have this. So universal health insurance. What would happen if suddenly the magic wand was waved at the federal level and suddenly everybody had platinum level health care coverage? How would that change the actual health of the population? So I see patients within a military system and they have platinum level. Their drugs are covered, they can see specialists when they want, there's lots of pills and procedures, they have behavioral components, preventative components, et cetera. What would happen if suddenly the entire country got that level of health care? How much would that actually change the health of the population? Give me a number. We talked about the medical education one, and we had numbers all over the place. 50%, so great. 50%, suddenly, that'd be a lot. 20% in those areas. Okay, we actually know how much it would cause. It's been tracked for many, many years, and they've shown what happens when universal health coverage occurs. In fact, there has been a large randomized controlled trial done on this. It's called the Oregon experiment. And they actually showed what would happen if suddenly a large part of the population got health coverage in those areas. The problem is it's not very much, okay? It's about 20%, 15 to 20%. The Oregon Health Experiment showed less than that, and it showed the costs went up pretty significantly for that. It did help, mostly in mental health areas, but very few other areas. We are asking the wrong question at the policy level. The question is not who should be paying for health care. The question is what kind of health care should we be paying for? Because if we have a health care system that is not delivering health and well-being, then what are we paying for? And why should we pay for that? So take pause before you say, let's just cover everybody with what we currently have. It may backfire on us. Let me give you an example with a patient with pain. And this is just an example of patient in pain. It applies to many other chronic illnesses. This is a patient who had platinum level health insurance. Her name was not Sally. I'll call her Sally in those areas. And she was an executive. She actually worked at the Pentagon, a civilian employee, ran a huge program, multi-million-dollar program. Very, very busy, under a lot of stress, but enjoyed her job. And she was driving to work on about 4 to 5 hours of sleep, which was her usual amount of sleep, and she got in a car accident. She rear-ended somebody. Okay, that in itself can tell you a little bit something about how she was functioning, but the car was totaled. She developed some back pain. She was taken to the emergency room in an ambulance. They did scans. They said, nothing's broken here. Here, have some non-steroidals and go to physical therapy and some bed rest and that type of thing. So she went home, she went to one physical therapy treatment, she started to take her non-steroidals, she started to feel better, and she went back to her job. And then about 3 months later, she was leaning over to pick up her suitcase, and she heard a sudden pop in her back, excruciating pain going down her leg. She could not stand up, and she said, oh boy, I've done something bad. Calls 911, they take her back to the emergency room, more scans, more x-rays, and since she'd already been on physical therapy and non-steroidals, they prescribed opioids. And she said, this is great stuff. I love this. It helped her back pain, okay? So she started to take it. She felt better, didn't all go away. She went back to work. Fast forward 10 years later. The more she took, the more tolerance she developed for opioids. The more tolerance she developed, the more she felt she needed them. And so she went on the cycle of trying to get pain relief and maintain her lifestyle and her behavior in these areas. She developed low back pain, a major problem that persists in this country, probably the most costly and most prevalent chronic pain problem we have. She then had platinum health insurance, so she got lots of other stuff. she began to make the cycle around all kinds of different people to help her treat her pain. Her primary care doc, the sports medicine doc, the surgeon. She eventually was sent, she got injections with steroids several times, which she wanted to do more of. She was sent over to behavioral medicine, and they gave her another diagnosis, depression, and they put her on another medication. And so now she was on about 4 or 5 different medications and told that she needed to go into some kind of recovery program to get off her opioids. And she says, I'm not addicted. And in fact, she probably wasn't addicted. Only about 15% of people even have a susceptibility to opioid addiction. Probably less than that, but that's the sort of one of the figures. And she eventually had to stop her job. She loved dearly, okay? Here was her team. She did a variety of what are called soaps by this team. All these teams delivered soaps. Anybody here not know what a soap note is? Everybody know what a SOAP note is? No. So a SOAP note stands for Subjective, Objective Assessment and Plan. This is what all of these folks do. And what that is it's the box in which when you go in to see a provider, they immediately put you in, and they have to put you in within about 10 minutes because then they have to write a note for it, and they get reimbursed. Subjective is what you tell them, objective is what they observe or measure, assessment is your diagnosis, and plan is the treatment. The assessment has to fit a CPT code if they're going to get it reimbursed. So does the treatment. Has to be so supposedly evidence-based linked to that treatment. Okay? She had had lots of those, and this was her so-called team. I put team in quotes because nobody talked to each other here. Okay? These were a series of people that she saw over the period of years, and they each gave her different advice. They provided different kinds of treatments, and nobody coordinated anything. There was no team here. There's no system of actually delivering the care. Fortunately, she was eventually sent to a surgeon. Unfortunately, the surgeon was not paid for doing procedures because they worked in the military, and they said, you have musculoskeletal low back pain. The 85% of low back pain is that. You are not a candidate for surgery. She was disappointed. She was hoping that she could get surgery, actually. If she'd been on the outside, she probably would have gotten it. It would have cost even more, and this is what resulted in her. She spent a lot of money, and she continued to have now multiple problems in addition to her back pain. Sally is not alone, as you know. You've all heard about the opioid crisis, right? All 2 presidential committees and multiple state groups, and we heard a lot about the enforcement of those types of things now that's going on around in the states. The prescription rate has gone up. The death rate was pretty high. 60,000 is, I think, the last figure, 64,000 in 2017. From what I hear, we're on track to even top that this year, despite all of the efforts. And nearly 12 million people are misusing opioids, using opioids when the evidence actually shows that not only does it not work, it actually produces harm in those areas. This is the tip of the iceberg, and we talk about in chronic pain that this is really not an opioid crisis. It is, but it is a chronic pain mismanagement crisis, and the opioid is just what's laid on top of that. And what I'm going to suggest to you is that even the chronic pain mismanagement process is laid on top of a bigger crisis, which is chronic disease mismanagement. We do not have a chronic disease management system. We are first in spending, but we're 37th in outcomes when you look at WHO criteria for these areas. We spend 25%, or will spend 25% of our GDP at the current inflation rate by 2025, 50% by 2050. Health disparities because of this rising costs are increasing. And in fact, the IOM showed over 30 years, our outcomes are getting worse. Compared to other rich countries, OECD countries in the world, the 9 of the top 12 primary outcomes that were tracked by the IOM, out in an IOM report called Shorter Lives, Poor Health, the U.S. is declining in those areas. And for the first time in about 80 years, over the last 2 years, our life expectancy has also started to decline. So we're not even getting impact on life expectancy. This slide shows the losing value that the investment in healthcare is occurring. And if our country was to invest in it, as it is, as it's practiced, we would continue to incur. The U.S. has over double the costs. This is cost versus life expectancy, and the U.S. spends over double the cost of any other country in the world, and yet its life expectancy is somewhere around Portugal, or between Portugal and Czechoslovakia, in those areas. We're not getting the value for health care that we're getting in chronic disease management in those areas. Why not? Because healthcare actually doesn't focus on what produces health. Most of health actually comes from outside of the office visit. The data shows very clearly, and this comes from multiple sources, but the best one is the University of Wisconsin's tracking system funded by Robert Wood Johnson, because they track county health outcomes on a year-to-year basis. It shows that only about 15 to 20% of actual population health comes from medical care, comes from the system of health care that we work in. The rest of it comes from three other areas, the bulk of it from behavioral and lifestyle approaches, how you sleep, how you move, what you eat, how you manage stress, and the underlying things that allow you to properly do those things or don't properly do those things, the social and economic impacts, sometimes called the social determinants of health, and then the physical environment. These are the personal determinants of health. If somebody walks into your office, these are the drivers for 80% or more of their own health and healing. And yet what I do in my office and what my residents do in their teaching is they ask about the 15 and 20%. So if healthcare is actually going to produce health, we have to get out of that top part of that circle and begin to be part of the solution, not the problem, and address these other underlying personal determinants of health that you see here. So in the pain area, finally, the guidelines are starting to say, yes, you should do something in this area. If you look at guidelines from the American College of Physicians, the CDC, the NIH, the Joint Commission, they all say we got to deal with non-pharmacological approaches to pain. These are the behavioral and the social components to deal with pain in those areas. So we have top-level guidelines. If we had listened to patients over the last 30 years, we would have realized that they were already doing this. We just called them complementary and alternative medicine. They were things like therapeutic massage, yoga, acupuncture, spinal manipulation, mind-body practices. And so we have the top guidelines saying do it. We have the patients doing it. What's the problem with us? What's the problem with us? We're not actually delivering it, and it's your average day-to-day provider like myself, primary care doc, where most of pain management occurs, that is caught in the middle. Because I wasn't trained on how to do this. I don't work in a system to do this. I don't get paid to actually do this. And I don't know how to put a team together to make this happen. And yet I'm told from all angles now that I need to start delivering these types of practices in those areas. This is not something that's going to be solved just by me as a provider. It's not something that's going to be solved by getting universal health coverage. It's not something that's going to be solved only by payers in these areas. It's a cultural problem. When Sally walked into my office after 10 years of having multiple SOAPs and lots of treatments, continuing to have pain, now on opioids and depression, the very first thing she said to me is, I'm not crazy and I'm not addicted. I'm in pain. And she sort of said it like this. Like this, right? Yeah. I mean, she was sent to me because I was supposed to provide now a whole person, whole care. And this is the average person that comes in, that sees me. They don't know what it means. The people don't know what it means to ask the kinds of questions that we heard about earlier that this clinic down in San Ysidro does, because they never get those questions from anybody. They get the questions that are about pills and procedures in these areas. So the first thing I do is I say, I'm not doing a SOAP note. I don't say that to them because nobody knows what a SOAP note is, even though it's the box you're getting put in every time you walk into a doctor's office. I said, I want to do an integrative health visit, and I want to do something called a HOPE note, and I give them what's called something called a personal health inventory. And the personal health inventory is something they can fill out in 5 minutes. The very first question is, what matters in your life? Not what matters for your health, but what matters in your life. Why do you get up in the morning? If you had good health, if you were free from health, what would you do, Sally? What would you do? What do you want to do in life in that area? And then it begins to assess what we know to be the complex components of a whole human being. I think it was called the biopsychosocial approach down here, right? Okay. It's asking the questions that we know drive health. External environmental components, behavior and lifestyle components, social and emotional aspects, and spiritual and mental components. And I do this with something called a HOPE note, which stands for Healing-Oriented Practices and Environments. It complements the personal health inventory. So we get into a dialogue. And it does the very first thing that has to happen every single day in the provider's office, which is you have to have a dialogue about health and the components and the determinants that create health in those areas. So here's what came out of that encounter with Sally. This is what mattered to Sally. The first thing she said is that I've got all these drugs now, and I've got different advice to take, and every time I come in, they're getting switched around. Somebody said, well, try Cymbalta, try, we've got a new one on the thing, and you can only get 3 injections a year, so let's do some saline injections and this type of thing. And we now have new devices. I know there's some device people here. We've got devices. We have acupuncture. Well, why don't you try acupuncture? There's a 3-month waiting list for it, but you can come in and get it, okay? Once or twice, maybe. She first wanted to know about medication management. So I said, Sally, all right, we've got on our team a pharmacologist that can help you organize this, and I need to have them on the team. That's part of our standard part of our pain management, pharmacologist to help with that. We're going to help get you your medication management. But what I really want to know is I want to know what you do besides take pills. Go see doctors and get procedures. What do you do from a day-to-day perspective to help manage your own pain? And she said, well, I found over the years that heat and stretching really help it. So I bought a hot tub. I get in the hot tub for an hour in the morning, and I stretch and stretch and stretch and stretch. And if I do that, I can usually get maybe through noon, after lunch, before I have to start taking medications again. So she was stretching, and what is that? Is there a evidence-based therapy that is available that maybe the American College of Physicians has now recommended and that patients have been using for a long time, that she was attempting to do? Does that sound like a therapy? Stretching. Yoga, yes. Yoga is one of the evidence-based recommendations for low back pain. She was using hot yoga. I don't know. Has there been multiple comparison randomized controlled trials of hot yoga versus cold yoga? I don't think so, okay? What's that? Oh, there was a comparison of hot yoga to warm yoga? Great, I'd like to know the results of that. For her, it wouldn't really matter because she already knew hot yoga helped her, right? She didn't know yoga. She wasn't doing yoga. I said, Sally, have you tried yoga? She said, sure, I tried yoga. I went to a yoga studio, and the lady was up there doing this and all that kind of stuff, and I hurt my back worse. Okay? Not for me. That was 5 years ago. Okay? What she had not gotten was a coordinated advice on how to do appropriate therapeutic yoga for somebody with pain. She'd just been told by a provider, gee, maybe yoga will help you, and she went to a yoga provider. It wasn't integrated, okay? It wasn't appropriate, and it wasn't evidence-based. She wasn't using the evidence-based components because nobody was there to advise her on that. Okay, let's put that aside. That seems to help you. Let's see if we can figure out if we don't have a yoga provider on our staff that's paid for, so we're going to have to talk about that. How about your sleep, Sally? It's fine. Well, how much do you get? I get about 5 hours a night. I've always gotten about 5 hours a night. Well, is it restful? I wake up 3 or 4 times a night. How do you feel in the morning? I'm kind of tired. That's why I get in the hot tub. Sleep, off. We already know that sleep is a core salutogenic factor for all kinds of chronic diseases, especially pain. Without sleep, you actually can't address the inflammatory processes that go on, and it is one of the major risk factors for chronification of pain. Okay? Nobody had effectively addressed her sleep issue because she didn't think there was a problem. How about stress? Stress? No, I don't have any stress. I used to have stress when I was running this, $100 million program at the Pentagon, on the plane, running all the time, 6 o'clock meetings in the morning, et cetera, trying to get the kids' stuff in the evening going and all that kind of stuff. That was stress, okay? Now I sit around and just try to take care of my back and wait till folks come home. I have no stress. Well, what do you do for stress management if you do have stress? I turn on the TV and have a couple drinks. That's how I relax. She was completely unaware that pain is stress. Stress produces cortisol surges. That produces inflammation. That aggravates pain. It's another aspect that was aggravating and chronifying her pain in those areas. Again, she was unaware. Now, if you did have a place where you could engage in self-care, maybe some yoga, maybe a little stress management, that kind of stuff, where would you do it? Thought for a while, she couldn't name a place. I said, well, what about your bedroom? A lot of people, that's kind of a quiet place. Oh, no. Bedroom is chaos. It's got, this wall's got to get fixed over there. It's kind of cluttered. I've always got to walk into the bedroom, and it's, I've got stuff to do, okay? And besides, the kids are always coming in and out and all that kind of stuff. Okay, she did not even have a place to heal. So she needed a time and a place to heal. And, the kids are coming in, all that. She needed the family to provide her time and space to heal. But probably the most important thing was what she wrote down on her little personalized health inventory, what mattered to her. She jotted a little down thing on the bottom that I asked her about. She said, what matters to you? She said, not being called Sally. What? What do you mean not being called Sally? Well, when I was working and bringing home the paycheck, I was called jokingly by my family Salary. When they started calling me Sally again, I knew I was doomed. She had lost she lost something really, really important to her because of the pain. And she was angry at her own body for doing it to her. Right? So that was the spiritual component of what was needed. That was the driver, the underlying driver. We had to figure out somehow how to hook that to the behavioral components that she needed. So, sounds discouraging, but we now know how to do it, right? We now know what her team actually needs to look like. And here's what her team looks like. She needed a physician not to provide her with treatments, but simply to be the coordinator of care with her medications, with the treatments, with the payment issues, that kind of stuff. She actually had Cadillac health insurance. There was very little payment, although there was one here. She needed a pharmacologist to help her manage the medication stuff, okay, because she was going to need to manage that. She needed a behaviorist, but not a behaviorist that was going to tell her she was depressed. She needed a behaviorist that would act as a health coach, support her in whatever behavioral changes she decided to do so that she could be successful at it in those areas. She needed a yoga therapist. She liked yoga, actually, but she didn't realize she didn't know how to do it. We did not have a yoga therapist. We had to find one who could work with our team, and we had to figure out how she was going to get paid for it in these areas. We needed her family on board. They had to come in and realize that she was going to be doing some behavioral changes that needed support from them. Time, space to do it. Most of all, we needed her mind on board. An attitude about her body. We need to somehow allow her to get an experience that her body was not the enemy. It was something that could be a friend. Okay? So she did this. We got her to a yoga therapist. Once we got the team organized, we had to have a couple team meetings to actually get that done. She went to the yoga therapist the very first time. She called me up and she said, my pain is down to 2. It hasn't been down to 2 in 5 years. Now, was she healed? No, she wasn't healed. She wasn't cured. But because of the way we had set this up, she began to actually do this on a regular basis, and within about 3 months, it was regularly down to 2, and in 6 months, she talked about going back to work again. Found her purpose in those areas. This is called integrative health, and this is integrating conventional care with evidence-based complementary medicine, and most importantly, self-care in those areas. And that's the term we use for integrative health. I don't see it anywhere on all the national policy components, but this is the kind of system we need. We can't just stay up in the orange circle there, nor can we flip over into any of those other circles by themselves. They have to be actually integrated. Where we encourage self-care as the primary target, we integrate conventional complementary and lifestyle approaches. The evidence shows when we do that, people actually get better, and we can prevent in those areas. Now, can we do this within our current system? DOD's doing it, okay? They're starting to implement this. VA's doing it. They just opened up this year 18 centers of excellence for what they call whole health approaches to complementary and integrative health. There's centers of excellence around the country. They have redesigned the whole model to provide this kind of care in those areas. So stay tuned. They're also evaluating it, as they often do. They're doing a robust evaluation in those areas. What about in the civilian sector? Let's see. Well, costs seem to be much more in the face in the civilian sector here. And we have started to provide integrative teams in certain areas, and we heard about it here, high impact chronic pain, right? These are the people up at the top 5% with advanced illness that cost 50% of healthcare costs. And so we're beginning to develop systems that hit that, but we don't have a system that gets the other 95% in those areas. And guess what? They're traveling in that direction. If they're down here and they're a Sally, they're going to end up there. And if we don't do something to actually prevent that, then we're not going to be able to control that on the top. In those. The top is called integrated care. It has care coordinaters. It addresses mostly the very high expensive components, emergency room visits, hospitalizations, et cetera, reduction in the use of specialist care, et cetera. And so we have actually systems that are now trying to do this, and some of them are actually working quite well. They're reducing some of the costs. But we don't have a system that gets at that other 95%. This is what I call integrative health. This is what Sally got when she came into the system. It focuses on health promotion and healing, lifestyle as prevention, and treatment. Not just prevention, not just wellness. It uses health coaches, integrative health practitioners, and it also reduces imaging, other kinds of medications, and supplements also. You got a lot of these people that are taking supplements in these areas. So there's a policy name for this. It's called value-based care, right? Okay. And we're trying to go from volume, okay, volume-based, fee-for-service type of to value. But right now we have 1 foot in the boat, value-based, and 1 foot on the dock. The boat is leaving the dock. If we don't get in the boat, we are going to fall right in the water. And that's actually what's happening in those areas. All right, so what can we do today? The magic wand isn't going to wave tomorrow, and the administration isn't going to suddenly give everybody health care insurance, especially the kind that we want, right? But we can start doing this day to day in our own practices. And here's what I teach my residents. I say, do an integrative visit. What does that mean? Do a personalized health inventory and ask the questions that are the underlying determinants of health. Ask those. Then add some simple techniques that are not simply drugs. Okay? Ear acupuncture, mind-body nutrition. There's a few safe supplements that a lot of patients take. You should know about those. You should be able to talk to your patients about those. Advanced healing technologies. We actually had a question about that today. Heart rate biofeedback is a great technology. CES devices, behavioral intelligence. Redesign your system. You've got the resources, most of the resources actually there, but it's got to be redesigned so that the team is like the second team she had, not the first team that she had in those areas. Health coaching, team care, group visits, shared decision making are all examples of that are out there. If you're a patient, ask for these things. Say, hey, I want an integrative health visit. Provide it. I want to have these questions asked. Do a HOPE. If they say, what is that? Go to my website, okay? I actually have free resources to tell healthcare providers exactly how to do a HOPE note, okay? You can do a HOPE note in those areas, and we're starting to add in reimbursement components in that. Make sure they ask what matters to you, ask the provider to do that kind of visit, and if they can't put together the kind of team that we just talked about with Sally, put your own team together. And you can do that, but get them to talk to each other in those areas. The Samueli Foundation has been generous enough to say, go forward, work with other groups, build these kinds of tools, get them out there. So we work a lot with the VA because they're developing tools like this that are totally free. We're taking other tools. If you know things that work in those areas, let us know. We like to actually put them on the website, simplify them, communicate them out there, and then point back to the developers and say, go there if you'd like more in those areas. So if we don't get on the boat, we're going to fall in. But I think that chronic pain and the appropriate management chronic pain is the opportunity that we actually have to not simply address the opioid crisis, but in fact to transform healthcare so that we actually produce health and well-being. Thank you.